Hello and welcome. Today we'll continue our obstetric and gynecology case file about urinary incontinence, and we reached the clinical approach of this case. So, neurophysiology. Urinary continence is maintained when the urethral pressure exceeds the intravesicular pressure, which is the bladder pressure. The bladder and proximal urethral are normally intra-abdominal in position, that is, above the pelvic diaphragm. In this situation, a Valsalva maneuver transmits pressure to both the bladder and proximal urethra so that continence is maintained. In the normal anatomic situation, the urethral pressure exceeds the bladder pressure, and also the pelvic diaphragm supports the bladder and urethra. Mechanisms of incontinence. Genuine stress incontinence. Following trauma and or other causes of weakness of the pelvic diaphragm, such as childbearing, the proximal urethra may fall below the pelvic diaphragm. When the patient coughs, intra-abdominal pressure is exerted to the bladder, but not to the proximal urethra. When the bladder pressure equals or exceeds the maximal urethral pressure, urinary flow occurs. Because this is a mechanical problem, the patient feels no urge to void, and the loss of urine occurs simultaneously with coughing. There is no delay from cough to incontinence. Urethropexy replaces the proximal urethra back to its intra-abdominal position. More recently, narrow strips of polypropylene mesh have been used to suspend the mid-urethra due to the theory that urinary incontinence occurs due to pubourethral ligament insufficiency. These procedures act as a hammock to support the urethra and also act to compress the urethra somewhat. These include various tension-free vaginal tape procedures, and outcomes are favorable as compared to urethropexy. That was about genuine stress incontinence mechanism. Mechanism of the urge incontinence. With uninhibited spasm of the detrosal muscle, the bladder pressure overcomes the urethral pressure, so dysuria and or the urge to void are prominent symptoms, reflecting the bladder spasms. Sometimes coughing or sneezing can provoke a bladder spasm so that a delay of several seconds is noted before urine loss. Overflow incontinence. With an overdistended bladder, coughing will increase the bladder pressure and eventually lead to dribbling or small loss of urine. So the mechanism of overflow incontinence, with an overdistended bladder, coughing will increase the bladder pressure and eventually lead to dribbling or small loss of urine. Workup. The history, physical examination, urine analysis, and post-void residual are part of the initial evaluation of urinary incontinence. Behavior therapy, including timed voiding and pelvic musculature strengthening, seem to have a role and generally should be the first line of treatment. So there is a small table here about the differential diagnosis of urinary incontinence, explaining mechanism, history, diagnostic tests, and treatment. I'll be reading this quickly. So, genuine stress urinary incontinence. The mechanism: bladder neck has fallen out of its normal intra-abdominal position. History: painless loss of urine concurrent with Valsalva, no urge to void. Diagnostic test: physical examination, loss of bladder angle, cystometric examination also. Treatment: urethropexy, Burke or Burch procedure, or urethral sling. Burke, Birch, or Burch procedure, or urethral sling to return proximal urethra back to intra-abdominal position. So that was genuine stress urinary incontinence. Urge incontinence mechanism: the trouser muscle is overactive and contracts unpredictably. History: urge component: I have to go to the bathroom and can't make it there in time. End quote. Diagnostic test: cystometric examination shows uninhibited contractions. And treatment: anticholinergic medication to relax the trouser muscle. Surgery may worsen this case. Then we have the overflow incontinence. Overflow incontinence mechanism: over-distended bladder due to hypotonic bladder. Over-distended bladder due to hypotonic bladder. History: loss of urine with Valsalva, dribbling, diabetes, or spinal cord injury. Diagnostic test: post-void residual shows large amount of urine. Treatment: intermittent self-catheterization. And lastly, fistula mechanism: communication between bladder or ureter and vagina. History: constant leakage after surgery or prolonged labor. Diagnostic test: dye into bladder shows vaginal discoloration. And treatment: surgical repair of fistulous tract. Okay, so finally we move to the clinical pearls of this case. The primary treatment of genuine stress incontinence is surgical, whereas the best treatment of urge incontinence is medical. Cystometric or urodynamic evaluation helps to differentiate genuine from urge incontinence. A post-void catheterization showing a large residual volume suggests overflow incontinence. Loss of urine occurs when the intravesicular pressure equals or exceeds the sphincter pressure. Thank you very much for listening, and please don't forget to like, subscribe, and comment. See you all inshallah in the next video for a new case from a new book
in a new day.